Hey guys, what's going on? This week in lab, we're going to be talking more about really taking the step away from just the basic vital signs, and we'll still do all that stuff. We're going to talk about how to take kind of a deeper, really deep look into what's going on with some of our patients. Now, the performance evaluations we're going to be focusing on are essentially auscultation, which is just going to be teaching you guys how to use your stethoscope and kind of how to systematically address breath sounds. And we'll kind of talk through some high points with this. And then we'll get into this advanced physical chest exam. I don't want you thinking that we do every aspect of the advanced physical exam, on a routine basis. Some of the things really do come in handy. Although, if you look back, what's happened over the last probably 10 or 15 years of respiratory with the advantages of readily available radiology, CT scans at an urgent care, and X-rays and stuff readily available. We don't rely on so many of these bedside assessments as much as maybe practitioners did in the past. Okay, so I do want to kind of give you guys a heads up that Danny and I are going to be going through this with you guys as we show up in class. There's just too many props and too many different angles of the video and stuff to shoot it. So we're going to break you guys down into groups, and we'll kind of go through this and give some better explanations. And there's always a couple of things that I like to be able to draw on a board with you guys there and just show you some of the different terminology and the different concepts and how they relate to the physical exam before we go in and start practicing on it. So I'll kind of talk about some of this stuff as we're going through this here today. Um, but there's more to be coming down the pipeline here for you. Okay. So let's start up with auscultation first, or listening to breath sounds. This is something that we do on a very routine basis as we get into different therapies and different medications and such. As the semester progresses, and even as we get into the critical care realm of things, you'll find that actually listening to breath sounds before and after some sort of an intervention, whether it's an inhaled medication or suction or something like that, that's kind of our part of our routine assessment. So auscultation is things that you are going to use on a routine basis. I'll show you guys how to use your stethoscopes. I'll talk about the different sounds and how to progress about the chest, and I'll show you that. I'll show you in the skeleton and or sim man, and we'll practice with some breath sounds, and we'll show you the difference. Some breath sounds can be very difficult to listen to in some of our patients, even though having your stethoscope in is, and even if you get a good stethoscope, is going to help kind of pinpoint some of these sounds and everything like that. Any ambient atmosphere, any ambient stuff happening on the environment is more or less going to possibly cover up something that you might otherwise detect if you had optimized that environment. So turn on the TV. If you're in an emergency room or something, and you're going to get these patients sitting up, and sometimes it's busy and you're in a hall, try and think about their privacy and everything too. Most of our hospitals are all private rooms, but if there's people around or something, just keep in mind sometimes people's gown fall off. They're not done up in the back or anything. So kind of keep their privacy into consideration as you're optimizing this environment as well. Put them in an upright position. So this is twofold. First off, if you want to listen to somebody's breath sounds, if they're laying flat in bed, all right, we're not going to be able to listen to the posterior aspects of the lung, which in my honest opinion, the lateral and the posterior aspects of the lung is sometimes the most important things, or in aspects, some spots of the chest to really listen to. When you think about some of the stuff you guys may be learning in anatomy and physiology, and some of the things I know you're going to learn in cardiopulmonary, a majority of the gas exchange actually happens in the bases of our lungs, right? So when you think about a majority of that pulmonary blood flow is really low pressure compared to our arterial stream. So ultimately, as that blood is leaving the right ventricle and going to the lungs for gas exchange, a lot of it, if you're kind of in a semi-upright position, it's going to be in the posterior and the basal or the dependent aspects of your lungs, so the lower parts. So if we just come in and listen to a couple spots in the front, not really doing a whole lot. We really want to be able to access as much of this chest as possible, and the posterior and lateral aspects are huge. Okay, so also where we're going to have these patients take kind of a larger than normal breath, very difficult, especially for some of our patients that are maybe morbidly obese or sick or all the above. Is really difficult for them to take a really good deep breath that we can really get some quality feedback on and everything like that if they're all hunched over. So getting them to sit in an upright position, honestly, a lot of the therapies we do in our C120, if you can get them sitting in an upright position, it's going to be a essential first step for a lot of things we do. Auscultation, always going to be best. And you got to kind of know the situation too. If somebody's really aching and you can't, sometimes you got to modify your approach, but ideally we'd like to get them sitting upright as best as possible, whether that's raising the head of the bed up or actually getting them sitting on the edge of the bed. So we're going to go ahead and make sure your stethoscope's warm. Okay, those things get a little bit cold and everything like that. Make sure it's wiped down. Sometimes in flu season, I'll try and make it a habit of wiping my stethoscope down in front of people and everything like that. Ideally, you're wiping it off whenever you're done with the room, so it doesn't matter. But kind of take that into consideration. We're going to use the diaphragm, so the larger aspect of our stethoscope. I usually, until you get it figured out, give it a little tap and make sure that that's actually what you're listening through. The bell, the thing that we're usually using to listen to more low pitch, low intensity heart sound type stuff. It can be, your stethoscopes can turn. Okay, so you don't want to think you're listening with the diaphragm, putting that big round part on the chest, but in all honesty, everything is clicked over where you're transmitting sound and vibrations from the bell instead. Okay, so we're going to be using the diaphragm. Make sure it's warm, not cold. If we can get these patients, just barely listening through a shirt, bare skin's always best unless they got a hairy chest, because then sometimes that causes a little bit of some artifact sound. You don't want to listen over a coat or a sweatshirt or anything like that. I'm not saying go in and tell your patients to take their shirt off all the time or anything. That's not what I do. But you really want to try and have a minimal piece of clothing. Don't be listening over a blanket or anything like that. All right. Ultimately, we're going to get that stethoscope in position, have them breathe a little deeper than normal. Okay. As you all start listening to breath sounds on each other in class, you'll notice that just normal tidal breathing. Okay. A lot of times that doesn't transmit enough vibrations for us to be able to really detect. So we got to try and get these patients to take a deeper than normal breath. All right. Taking that breath in through the mouth works a little bit better and a lot of times more comfortable for them and everything like that. Sometimes, like if I were to breathe through my nose would be whistling if I'm trying to breathe too deep through my nose. So if you can get them to kind of take a breath in through the mouth, most patients are going to kind of do this naturally anyways. What we want them to do is take that effort to take that deeper breath in, but make sure exhalation is passive. They shouldn't because that causes a lot of other artifact noises because we're making more turbulent airflow and vibrations and things that sound like wheezes. So I usually tell my patient, nice deep breath in, all right, and nice and easy out. And if you notice they're pushing the air out, just tell them just nice and easy out. Don't force that air out or anything like that. The biggest part about listening to the chest is making sure that we're doing it systematically. We want to cover as much chest as possible, and it is essential that you compare side to side. Okay. Sometimes if I listen all the way down my left lung and then listen to my right lung, I may not pick up on stuff. But what we're trying to do is make comparisons. Okay. So regardless of where you start or where you end, you need to, if you listen to one spot on the right side, you need to jump across, listen to the same spot on the left. As we're trying to listen, even though your diaphragm is pretty wide, we're trying to ultimately focus on getting in the intercostal spaces. Not that listening on bone is going to interfere with anything, but you're trying to kind of hit all the intercostal spaces. As we're listening over bone, it's not going to transmit those sounds and vibrations as well. And that's something you guys to kind of get used to. All right. Whether you start on the front or whether you start on the back doesn't really matter. Your textbook, as our handout is saying, and I know as Lindsay teaches you in class and stuff, theoretically, you're supposed to start at the bases and work your way up. And the rationale behind this is if a patient is not breathing really deeply and getting good lung expansion, you could have little air sacs and airways that are kind of prematurely closed. If you listen to the bases, you'd be detecting this stuff at first and they wouldn't go unnoticed. Sometimes if you have them start breathing deep and you're starting at the top, you may not notice this, and by the time you get to the bottom, they've expanded and stretched your lungs enough where you're not here, and you miss out on these little crackles and these little air sacs and airways kind of opening and closing and everything like that. Not the end of the world. I'll be completely real with you. I listen to patients from top to bottom. All right. I don't have a good rationale aside from the fact that a lot of the patients you get called for have a prominent upper airway noise. I feel like my last few jobs I've been, the patient assessments that stand out the most are always the ones where you're getting called to assess the patient having respiratory distress and they think they need a nebulizer treatment or something. You hear wheezing, but it's prominent in the upper airway. So I typically start mine up top. If you start down low or if you start up top, I'm not going to mark you wrong either way. Okay, just realize that's why your book says it. I start from the top and work my way down. Typically speaking, I always start on the front, get that out of the way, and then really focus on the backs and the lateral aspect. We're going to show you handouts. I'm going to show you in class essentially a number of spots that you should be listening to. For a man, we're very limited. Sometimes on a female, I may not be able to listen to a lot of spots in the front without kind of making them uncomfortable or worrying about getting in trouble or something like that. So I don't want to pigeonhole you with a maximum or minimum number of spots or anything. But as we go through, we're going to kind of talk about how you kind of navigate your way through. A lot of times I'll try and do 5 pairs on the front, okay, and I kind of start middle of the chest here, and then as I kind of get down past the nipple line, I start branching out and doing more lateral aspects on the back. Try and do 9, and at first you're going right in between the scapula, having them kind of roll their shoulders forward and everything like that. And I'm going side to side, working my way down. And then as I get down past the scapula, I start branching out and can really hit the lateral stuff. Your book will have you do 9 spots, and then it gives like another 4 on each lateral aspect. So I don't want you thinking there's a distinct number of spots you got to listen, but you just think about it. You're trying to cover as much ground as possible. If I come into a room and listen here and here, yeah, first off, I'm not really covering much. Okay, I could have profound things happening in my lungs. And once again, the most part where gas exchange is happening is really in the bases here. Okay, so you really want to listen to those lateral and lower parts. The biggest thing we see students do wrong is not knowing where the lungs end. Okay, and they're listening to kidneys on the back and stuff. So I'll show you on our skeleton where we should kind of try and be syncing up with and everything like that. Biggest other thing, as we're talking about specifically how you're listening to the breath sounds in a particular area, full ventilatory cycle, meaning we want to hear full inspiration, full exhalation. Sometimes you'll hear a faint little end expiratory wheeze or something that if you're just running through, you're not getting a full appreciation. So we want to hear the total component of inspiratory and expiratory gas flow. So we'll talk more about the handout and talking tracheal and vesicular and bronchovesicular and all this stuff. There are subtle differences just on how normal breath sounds might come across to your ears as you're listening to different parts of the chest. And a lot of that has to do with how air is kind of moving through there. And, think about it. On my trachea, I got a ton of gas flow going on in inspiration and expiration versus my bases of my lung. It takes a little bit longer to get that air down there. And, as soon as it leaves, I'm not hearing the same. What we typically do is draw a picture for inspiratory and expiratory to kind of relate them. You're not going to hear equal phases all the time. So subtle little differences in breath sounds are normal depending on where you're listening across the chest. Nobody typically gets that specific on it. But we'll talk about the adventitious breath sounds, and I'll tie that in with some of the things we'll talk about in our next part of the assessment here. Okay. So you listen to the full ventilatory cycle in each location, and then we go ahead and chart it. All right. We're going to go ahead. Sometimes you're keeping that in mind. You're starting a therapy, and then we're listening for signs of improvement afterwards. Okay. So when we get into listening for signs of improvement, it's not just the sounds we're hearing, but think about the total quality or the total amount of aeration too. If all of a sudden you're hearing a ton of air movement afterwards, all right, and you weren't hearing a lot of air at the beginning, that could be a sign in itself, even if the adventitious or abnormal breath sounds haven't changed. But the fact that how much air you're hearing can be a good thing as well. Okay, so if we're doing just a routine assessment, you might just be doing auscultation once, but typically speaking, as we're doing interventions, you're going to be listening before and after. Okay, and once again, more to come with that as we get into the class here. Let's talk about your advanced physical chest exam. Okay, so this is something, there's components of it that we tie into our everyday. All right, there's a lot of components you may never really use, but you'll see some physicians use it, and it is important. Your board exam still hits on this stuff quite a bit. Keep in mind, you guys will be doing this in Lindsay's class for 130, so we'll kind of be getting a head start on all this stuff here, okay? So as you come into the room, you'd still do all the same stuff. So, this particular checkoff forgets, standard precautions introducing a patient. You guys, a vocabulary share, probably won't have that out till tomorrow, but some of the things that you're going to get tossed around the physical exam that you might see, okay, and might hear and everything like that. So how can we assess somebody's level of consciousness? Just by talking to them. Do they seem like they know what's going on, or you talk to them and they're crazy? Do they not wake up? All right. Once again, that level of consciousness, we're worried about things like, it depends on the context of our visit, emergency room versus floors, but hypercarbia, CO2 building up due to ineffective breathing can make you sleepy, drugs, head injury, Somebody's in a post-ictal state from a seizure, a lot of different things that could cause alterations in your level of consciousness, profoundly low oxygen, things like that. We're looking at, so we're still going to be doing respiratory rate, okay? And that's what I don't like about this particular checkoff. Um, we really need to be thinking rate because rate's important, okay? But we also need to be thinking about the quality of that, looking for normal breathing versus abnormal breathing. So increased work of breathing, whether that's nasal flaring. All right, and the handout does a good job talking about this. Is somebody cyanotic? So got that bluish discoloration, typically significant for poor oxygenation, low saturations, things that we should spot. Pursed lip breathing. So advanced lung disease, people with obstructive lung disease, COPDers and stuff, they'll use pursed lip breathing as a technique to kind of splint their airways open and prevent this premature collapse. You guys will learn about. Another thing you'll see, tripod position. So they're using their arms as an extra little mechanical advantage to kind of expand their chest and everything. So you can come into a room and get a good feel for that patient if they're sitting there, hanging back, watching TV, and you're talking to them versus you can really get a whole lot, and you can tell if somebody's maybe looking in a worse state versus somebody that appears to have no current respiratory difficulty or anything like that. Along with this, I'm counting respiratory rate. I have a very different way of counting respiratory rate. I count the time in between breaths and kind of extrapolate that out. But you could do this as part of your other, vital signs type check and everything. So we're looking at not just the respiratory rate, but we're looking at the quality for respirations and the obvious signs, whether it's extra accessory muscles. All right, the patient's kind of positioning, cyanosis, whether it's central around their mouth or peripheral in their hands and everything like that, or the pursed lip breathing that we talked about. If you look at the side of their neck, jugular venous distension. So there's certain conditions where blood can kind of back up at the right heart, all right? And we get this big prominent jugular vein. Looks very, very distended and gorged with blood, okay? It can be a sign of underlying pulmonary disease that's been going on for a long time. That pulmonary artery gets kind of constricted due to poor oxygen status and everything. Sometimes in these patients, alveoli, all right, that right heart has to work harder, and what you get is right ventricular hypertrophy, and everything kind of backs up. Okay, what we'll see in some of our patients is something called cor pulmonale, or ultimately heart failure that's secondarily kind of like an underlying lung problem. Okay, so we're looking for that. You're just looking at it, okay, and it can be a sign of heart failure. Now, we're talking right looking at it, okay, and it can be a sign of heart failure. Now, we're talking right heart failure, any sort of backup and engorgement of fluid and things not pumping its way through the heart. You can see that the thing, right side of heart failure and everything like that. We don't make you measure it, but I remember in school there was a whole process for measuring it and everything like that. Tracheal position, you can kind of find the tracheal patient's trachea. It should be nice and midline. Sometimes you really got to get your hands on and kind of palpate that. We'll talk about how to kind of find your trachea and kind of pinpoint it. It kind of feels like you're poking and prodding and stuff. You can kind of access that upper of your suprasternal notch here and everything. So we'll talk more about that. Sometimes you can see major changes as different things are happening, whether that's a collapse of the lung and it shifts everything towards that side, or whether you got abnormal accumulation of something, pneumothorax, air in that pleural space, and it pushes the trachea away. So trachea not being midline can tell us some underlying things that could be causing problems for our patient. Thoracic configuration, we're looking at the quality of that patient's really chest makeup and everything. We're looking at not just, anterior to posterior diameter, so looking at from the side. Some of our patients with obstructive lung disease, they trap air and they'll have a really big, kind of puffed up barrel looking type chest. Some patients have abnormalities with their spine that can cause restrictions. So you got, scoliosis and kyphoscoliosis and stuff like that. That obviously can cause some underlying problems with lung expansion and can have an effect on some of our patient findings as we do our assessment. Okay. Likewise, sternal deformities. I'm sure everybody's been to the pool and seen somebody with like a sunken and crazy looking sternum, pectus excavatum. I had a friend with pectus excavatum who always knew it was funny looking. I didn't learn what it was until I was in school. And then you got the opposite, pectus carinatum, kind of pigeon chested where it sticks out a little bit. Typically, the excavatum can cause a little bit more problems than the carinatum. Typically, not nothing tremendous or anything, but we're kind of looking for some of that different stuff. Likewise, say you're working in trauma and you're doing this, okay, is something grossly deformed with the thoracic configuration? Is something broken? Is something protruding out? Is something not moving the way it should or anything like that? And we're going to kind of look at expansion here in a second, a little bit different. So really, even though this next step is assess the patient's breathing pattern and effort, I'm kind of looking at that as soon as I walk into the room. We're respiratory. I can't really skip that step. Okay, so I'm looking at that number of respirations. I'm looking at the work of breathing, like we talked about early on. But we're really looking at that patient's effort. All right, as I already mentioned, and then the pattern. So, is your patient? It's just because we go down the rabbit hole. They sort of saying in your auscultation here, you say 99, you'll feel vibrations. Okay. And all we're doing is assessing vibrations side to side. And is there abnormality? Did this not vibrate as well as the other side? If I just go down the chest and not compare side to side, I'll probably not detect anything ever. Okay. It's all about the comparison. Percussion. So percussion is also a different little hands-on technique that allows us to assess what's the underlying lung tissue. Percussion is something that actually its roots go back to olden days, people trying to figure out what's in a wine barrel. Okay, if you go and tap on a big wine barrel you can't see any, you want to know where's the air fluid line, start tapping, and then as soon as you get on the spot where that fluid is, it'll make a different noise. Okay, so we'll talk about this resonance, and is this a normal resonance or tympanic sound? Is this hyper resonant? Is this dull and flat percussion? We'll talk about what those type findings can mean. I'll be honest, I can't describe percussion notes to you. I got to compare side to side. Okay. With this, you have to get a finger. I'll put my hand on the chest and I usually use my middle finger. I'll put my middle finger in an intercostal space and you got to use the bony tips of your finger and really wrap on it really, really hard. All right. And you'll hear vibrations, but you got to beat on your hand like crazy and everything like that. Okay. What we're doing, same deal, progressing all over the chest, going cover as much as we possibly can, side to side. You have to do side to side, okay? I'll be honest, this is not something that we do routinely. I haven't done full-on systematic percussion on a patient since I was in school, aside from doing demos in class and everything like that. The one instance where this comes into play, because keep in mind, these techniques are all kind of falling out of the wayside with the advances and advantages we have of on-demand radiology, okay? If we have a patient who's on a ventilator and we think that something's happened and they've had a physical rupture and they have an air leak going into their pleural space and something called a pneumothorax or air accumulating in the pleural space. Tension pneumothorax is one that gets bigger with each breath and it's like a one-way valve, starts to compress the lung. This is life-threatening. Sometimes I don't have the ability to wait for a chest x-ray. So you'll see sometimes I'll listen on the at the bedside, a lot of bad things happening with the patient vital sign wise and ventilator wise. I'll notice some abnormalities in auscultation. But sometimes we'll have to put a chest tube in on a patient, essentially open them up and put a big giant needle tip through there to try and evacuate that air. Otherwise, they can die. Sometimes it's me, a nurse, and a physician at the bedside, and we're looking and going, I don't know. And I've used percussion. You'll see physicians percussing, but it's very, very hard. I wouldn't want that to be my job to have to tell if somebody's hyperresonant percussion and whether or not I'm going to put a chest tube in them or anything. But you can tell a little bit of a difference if you do it right some of the times, okay? But that's the idea there. And once again, I'll show you how to kind of progress through this stuff and everything. PMI, we'll talk about listening to heart sounds a little bit more. I'm going to show you more or less. I got to show you a bunch of different landmarks to be able to show you how to even find the PMI on a patient other than find that fifth intercostal space. So I got a trick for teaching you how to find the second rib, and then that's the easy way to kind of progress down. I'll show you the skeleton and everything, but we'll talk about heart sounds a little bit and where you can maximally find those heart sounds. Okay, not something we typically routinely do a lot as respiratory, unless can't find a pulse, trying to figure out if somebody's dead or something like that can be useful. And then abdomen and extremities. Okay, so I'm looking at your abdomen when I come to the room. You might go, why do I care about the abdomen? Why do I care about the extremities? And that's an excellent question since we're respiratory. Good things we'll get into in ventilation later on, or even in cardiopulmonary. If my belly is swollen up, whether that's just because I have a big old beer belly, or whether that's because I got some sort of pathology taking place that is causing my abdomen to swell, whether it's fluid accumulation or bleeding, something bad going on, is that begins to fill, it can compress my diaphragm and it can cause problems with chest expansion. So it can be very, very important and everything like that. Especially when you show up to a situation you don't know what's going on with the patient. Abdominal swelling and different things taking place can have a major effect on how we deal with somebody, at least in the intensive care unit and stuff. But it could cause problems with the breathing long before that. And it's something that is often overlooked. We start thinking respiratory, I'm belly buttoning up, right? It all plays a part. We got to think about everything that's going on in a patient's body. Okay, so we're checking, seeing if it's swollen, seeing if it's tight, or seeing if it's nice and pudgy like Pillsbury Doughboy. Okay, seeing if they're tender anywhere that can lead us down some other pathways. Once again, that's more of the kind of physician's concern and everything like that. But I'm more or less assessing tenderness, distension, stuff like that. Are they really, really tight, or is it nice and pudgy? Patient's fingers. So Danielle's got some great pictures in the handout that shows cyanosis and digital clubbing. So we get peripheral cyanosis and the digits and everything, and the digital clubbing. Some things that we see, cyanosis can be shown up just on an acute type situation. It can also be a chronic type underlying problem with the patient. We'll talk more about what that is. Clubbing, it can be a sign of like chronic hypoxemia or chronic been low on oxygen for a long period of time. You got to be careful though. My dad, he's got Martian club looking fingers and his oxygen is fine and stuff. We just got weird fingers, but the ones in the handout are very, very kind of crazy and extreme looking. So we're kind of looking at the digits. Okay, we're going to go ahead, and if you take your own finger, you're not going to see it because I'm doing this in the evening time on my front porch and stuff. But we'll assess capillary refill. So it's a good, easy way to assess how well somebody's perfusing their extremities by squeezing that capillary bed until it blanches or turns white, and then release. Most people that are healthy, you'll see that thing pink back up within less than 3 seconds, or in my case, almost instantaneously. Okay, as we start getting that past the 5 second range, we're not really perfusing our extremities that well, and that could be something that's acute, that could be something that's chronic, but that's usually not an entirely great thing as far as level of perfusion and everything goes. So we're assessing that, and then you can kind of I don't like touching hospital feet, but I'll look at somebody's feet. Okay, hospital feet really gross me out. But you'll hear pedal edema, or a lot of times we'll call this, lower extremity edema and stuff. Pedal, we're talking feet. If you look at somebody's lower extremities and they're super swollen and edematous and look blown up, bloated, all right, they got all this extra fluid. That can be a sign of the excess fluid on board. That can be a sign of congestive heart failure. Sometimes it's just gravity dependent stuff. A lot of times there's something underlying going on behind the scenes. A lot of our patients we see have congestive heart failure and chronic fluid backup, and it causes problems with their breathing. Okay, so it can be very, very useful. Even though the things we do don't treat it, there's certain things that it can be beneficial when we know that that's the underlying problem, or it can lead us down a different pathway. Okay. So looking at pedal edema is very, very important. Sometimes you don't even have to go as far as looking at somebody's feet. You can look, I'll check their pulse, and you actually leave finger imprints, and it's called pitting edema. All right, so you actually leave an indentation, and it'll show you some pictures and talk more about that and everything. Okay, so this is just the talking you through stuff. I'm still going to go through things and everything like that in class. I'm going to show you these techniques, how to apply this, and we're going to talk more about the findings and stuff. I just want to give you a little bit of an intro. If you don't need this and you do fine with the handout, that's totally fine. I just kind of want to explain and kind of summarize all this different stuff. I hope everybody had a good Labor Day, and I'm glad I didn't blind myself in this video or anything like that. Hopefully my connection wasn't too jacked up from doing this here at home, but I will see you guys here this week. Email me if you got any questions. Take care. Bye.